Hello and welcome back to our series. We're grateful you're here. We are always expanding our educational offerings, including our growing collection of programming, led by Doctors Armin Smith and Jeannie Hoffman-Sensis, and the program team members, Pamela Getz, Samantha Rockler, and Stephanie Cooper-Greenberg, specifically tailored around the experiences of women with bladder cancer. See our website for the next virtual women's group. Additionally, we have been working with our clinical providers to assure our GBCI front door for care is easy to access. We have two email addresses, bladdercancer@jhmi.edu, and a more specific email address for upper tract urothelial cancer patients, utuc@jhmi.edu. Before I introduce today's session, I'd like to remind you that you can find our updated programming and useful resources on the web, including a new one-page bladder cancer patient navigation aid designed to help our patients understand the complex relationships between our unique teams and departments across the GBCI. You can download a copy from our website landing page or email us at bladdercancer@jhmi.edu to request this valuable tool. While on our site, I encourage you to take a look at our previous Grand Round series that are all viewable through YouTube. Please also mark your calendars to join us next month, April 2nd, for a panel discussion with Doctors Nirmish Singla and Jeannie Hoffman-Sensis, who lead our UTUC program. Hear from them about our work to stand up a novel multidisciplinary care model focused on UTUC. I'm looking forward to an engaging discussion. Again, more information about all our programming can be found on our website. Just Google Greenberg Bladder Cancer Institute. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm grateful to all of you for joining us today for a conversation about a novel care model for high-risk non-muscle invasive bladder cancer with its leaders, Doctors Max Cates and Noah Hahn. Dr. Cates attended Mount Sinai School of Medicine in New York before completing his internship, residency, and urologic oncology fellowship at the Brady Urological Institute in the Johns Hopkins School of Medicine. He's currently an associate professor of urology and oncology with a clinical practice and research program that focuses on patients with bladder cancer. Dr. Hahn earned his MD from Indiana University School of Medicine. He completed his residency in internal medicine at Duke University School of Medicine and performed a fellowship in medical oncology at Indiana University School of Medicine before joining the Johns Hopkins faculty in 2014. His practice is focused on caring for patients with bladder cancer, and he's the clinical co-director of the GBCI. He is currently conducting clinical trials to test new therapies for bladder cancer with a focus on non-muscle invasive disease. As leaders of the new multidisciplinary clinic, Doctors Cates and Hahn work together to deliver a personalized approach to non-muscle invasive bladder cancer using cutting-edge precision medicine approaches. I'm grateful to have them with us today, and we'll turn it over to them and include Stephanie Greenberg to participate in our discussion. So maybe we could start with you, Noah. Maybe you can give us a brief description of the vision you have for this clinic.
Sure. Thanks, David and Stephanie and Wasim for having us for these grand rounds for the GBCI. It's always a pleasure to reach out to our patients. I think our vision for the non-muscle invasive bladder cancer multidisciplinary clinic, which I realize is a little bit of a word salad, but it's the NMIBC MDC. The inspiration for this, I think, came from our long-standing multidisciplinary clinics for muscle invasive bladder cancer. And we learned over time, those took a while to really become established, not only at the GBCI, but across the country and the world, and now our standard of care. But I think we learned from those experiences that not only do we deliver better patient care and better outcomes when we put complementary disciplines together with a focus centered on the patient. I think we also have learned that innovations can happen from sort of having a culture of collaboration and teamwork within sort of the physician team, support staff, and everyone involved in the care of patients. And so the non-muscle invasive bladder cancer multidisciplinary clinic, the inspiration came from muscle invasive, but what really, I think, accelerated both the vision and the need for it was an intersection of clinical care and developments, both in our understanding of the biology and targets for non-muscle invasive bladder cancer patients, but also drug developments. Historically, there'd never been a role for systemically administered treatments. And what I mean by that is any treatment delivered outside of the bladder. So for non-muscle invasive bladder cancer, we're very familiar with intravesical treatments. And I think Dr. Gates will talk about that quite a bit. But we had never had a role for, say, for instance, intravenous treatments, oral treatments, targeting specific genes or specific targets. We at the GBCI started to see that influx through clinical trials, but I think we could also sort of see where that was going to head in terms of ultimately drug approvals. And in the last 3 years, we have seen some of the immune checkpoint inhibitors make their way into the care of some of the highest risk BCG unresponsive patients. So our vision, I think, was to create a place for patients to get the best information about their options, to provide them with expert care for their clinical cancer, and hopefully to provide a vehicle for us to not only just begin that journey of improvement, but hopefully understand the disease better and try to develop new innovative therapies to help patients do even better than they are today. So I think that was sort of the nidus of it. Max, I don't know if you want to kind of comment a little bit about that as we developed this. I know it's been something, it's taken a couple of years for us in the concept stage, but to actually have it here now, what we're talking about today.
Yeah, I mean, I think, there's the philosophical conversation about what I think makes this unique, and then there's kind of the nuts and bolts of like, how do we offer the most broadly and the most broadly with access. So, speaking philosophically, which I think is a very interesting place to start, because that's kind of where the field is. When we think about bladder cancer, I mean, we look at the way it's treated historically and still today in most of the world, and definitely most of the United States. And basically, if you have a certain stage of disease, you're treated in a very specific way. So if you have non-muscle invasive bladder cancer, we say, okay, we want you to keep your bladder. Whether that's the right thing or not, that's what you need. And we're going to give you multiple rounds of treatment with the goal that you're going to keep your bladder. But the moment that tumor gets into muscle fibers in the bladder, we have a completely different philosophy right now, where we say, okay, now the bladder's got to come out. Well, wait a minute. Just because it got a cell layer deeper, you're telling me that like this whole philosophy of that we had yesterday doesn't matter? And then this we say yes. And then we say, okay, well, if it's gotten into a lymph node, now you have metastatic disease, and we're definitely not going to be removing your bladder. You need to see a medical oncologist, says the urologist, and you need systemic therapy. And that's basically the history of the disease. And really what we've found, particularly over the last maybe 3 to 5 years, is that that's not probably the right way to treat the disease. But we're handicapped by the current health system environment we're in which we're siloed, in which patients see one doctor, and when you see a doctor, they're going to try to take care of a patient using the tools that they have in their toolbox. And so how does that relate to what we're trying to do? Well, it relates to what we're trying to do because actually the more we learn, thanks to some of the breakthroughs in the GBCI, what Dr. McConkey's been able to accomplish in his career, and what others have been able to accomplish in sort of understanding that, hey, it's not just stage, but it's the biology of these tumors that matters. And this idea that our management strategy is going to be confined to stage alone, we've kind of turned on its head. And so we basically, and we're doing that across the disease space. But the way it relates to non-muscle invasive bladder cancer is basically we're saying, okay, our goal is obviously going to be for patients to preserve their bladder, for patients who have a functioning bladder. Many patients, get up 6 to 8 times at night. They've had a history of radiation for a different disease. And in those situations, we ask the question, is this a bladder that, you have a high quality of life having? And sometimes the answer is no. But putting that aside, the goal usually is to preserve the bladder, but we're learning that there's multimodal ways to do that. As Noah said, sometimes that's intravenous therapy, sometimes it's intravesical therapy. But we also want to know, okay, well, what tumors are going to be resistant to anything we throw at it? And what tumors are we understaging where we think we have non-muscle invasive bladder cancer, but actually that's probably not the case. They're probably either at a high risk for progressing rapidly, or they already have and we just can't see it yet on a scan. And that's where some of these more elegant sort of markers, I know we've already had a grand rounds on circulating tumor DNA and things like that. So I would say, starting at the broadly philosophical and kind of saying that the way we've probably been treating cancer, at least bladder cancer, is probably incorrect. And we're trying to sort of right that ship by approaching sort of the patient holistically, sort of almost agnostic to stage, basically looking at the biology of their tumor, and approaching the disease in a multidisciplinary fashion using our combined toolbox, not just one urologist or one medical oncologist toolbox, allows us to look at the situation in a way that is wholly unique, and very particular, and we hope a example that will allow others to sort of follow.
Stephanie, did you have any questions for them?
Oh, I have so many. Thank you for. So the first question is, this particular, I understand it's high risk, non-muscle invasive. So you're selecting a certain group of patients, and I sort of see it as you're trying to keep them from falling off the cliff, which is no one wants, from progression, from metastasis, from bladder removal. It's almost like bladder cancer is bad enough, but you want it to sort of stay where it is. And you're dealing with people who are really in a this could go places and go places no one wants it to go. So first of all, thank you for concentrating on this particular specific group of bladder cancer patients. You're sort of trying to stop things from progressing and also treat them with new things. Because again, back to staging, I'm not you, but superficial, don't worry about it, to high risk, there's a big, there's a lot to pay attention to. So my first question is, how, just to paint a picture of how this works, could you describe what it is for a patient to come to your clinic? What actually hypothetically happens? So that they could sort of say, well, you walk in and then what goes on and what do you talk about and who sees whom? And
Sure.
I think that really helps sort of place it in terms of care.
Well, I think I can tell you, so our non-muscle invasive bladder cancer MDC sort of had a soft launch April 1st of 2023. And then after about 2-3 months, we kind of said, all right, this is our kind of full clinic that we have. And typically it's on Mondays. Max and myself have clinic together on Mondays in urology, in the Levi Watkins Outpatient Center, physically, literally next to each other in the same clinic.
Mm-hmm.
And we usually have new patient slots, typically about 2 to 3 new patient slots that are there every week, you know, for multidisciplinary consultations. And the way that it works is that patients come to the clinic, and then both myself and Max see them same room, but sequentially. Either Max will see them first, then I'll see them next. And we talk to the patients about, you know, our perspectives from sort of our specialty about how we view their disease, their non-muscle invasive bladder cancer. What the options are that we can provide, you know, as far as standard of care options, as well as clinical trial options. And then we speak to them about, you know, what our recommendations would be together. We don't strong arm a patient into, you know, a specific therapy or that kind of thing. We really want to provide them information that they may not be getting in that format, you know, in a traditional clinical setting on either side of the fence, you know, oncology or urology. So we really try to put the patient at the center, and try to answer as many of the questions they may have about their care that they've received or their options moving forward that they have at that stage. And if they choose to move forward with the therapy, you know, at the GBCI, that's great. If it's a therapy they can get closer to home and it's something they want to pursue, then we communicate with their, you know, their other doctors. And if they want to pursue a clinical trial, then we connect them with our clinical trial staff to try to move that process forward. I'm trying to think if I've summarized that pretty well. I mean, it flows. What it's not, I mean, I'll say right now is it's not an entire, you know, full day, 8 hours of just one freestanding, you know, MDC. It may evolve into that at some point, but right now we're sort of building it as the capacity grows.
See. And how do you select the patients who sort of are in the right medical space for this? Not everyone is high risk non-muscle invasive, and we hope they never are. But there's a certain self-selecting patients who are appropriate for this care. Is that right? And how do you what are the criteria for that?
Yeah, I mean, basically, the way I would answer that is any patient where where we feel like there is that one of the options involves the other sort of field per se, is a candidate. And so it's very hard to say, okay, well, that's this exact type of patient, because honestly, the bar is moving on that. Noah right now is going to be principal investigator of a trial for newly diagnosed patients with bladder cancer to combine some systemic agents with BCG. Similarly, he's investigating a group of patients with recurrent low-grade non-muscle invasive bladder cancers for an oral drug. So the bar of what is a patient that may receive sort of multidisciplinary care is changing based on, to be honest, our collective attempt to push the envelope in that way. So for that reason, but yet we only have a few slots, you know, every Monday. So for that reason, patients who are interested often will contact our offices. Amazingly, we've recently been able to hire a nurse practitioner for non-muscle invasive bladder cancer that has begun to start triaging, basically going through these cases to help and work with us to help identify patients that this approach makes sense. But that's the general answer.
On
So,
that note, Karen,
you got it.
Karen Sachs at Innova, she's a fantastic friend on the board of Beacon, and just a great advocate. She asked about that. So how do you get access? So I guess you just contact UMax or your NP or NOAA or
Office, yeah, and sometimes we've had a couple of patients who have specifically said, well, we would like a multidisciplinary evaluation, and absolutely, those are patients will likely, you know, more than not, we're happy to do that. But there's a whole host of other patients that either don't know about it or don't know to ask, and we are actively like going through those cases where they might only be seeing one of us and sort of shifting them to a multidisciplinary clinic visit
you
where we
only
think
have,
it's appropriate.
it's fairly new model. And then the fact that you're both in the same building, in the same offices next to each other, it's almost like a joke, you know, the oncologist and the urologist walk into a bar together. And that's fairly rare, you know, to have the one appointment.
Well, we walk into a bar together periodically, so it's not that rare.
In your since practicing together and two minds, your collective wisdom and so forth, have you been surprised by how well it works to have this model of care? And that's not a softball question. It's just the real patient is there and you're analyzing everything all at once. How has that helped you inform care decisions when you're sort of both together and not texting each other late at night or whatever, you know, how it normally works, which, you know, is completely overbearing and
Yeah, I mean, I think I guess I'll say a couple things. I don't know that I'm surprised that it's worked so well, because I think both of us sort of understood that there was such a big gap, like a need for it. And I think sometimes some of the biggest value we've added a lot of times is just the education and letting patients know what the options are. But I will tell you, it works a lot easier and a lot more efficiently because we're there.
Okay.
These can sometimes be you know, complicated medical decision making where the patient may have you know, aggressive disease, and they may have, you know, medical conditions or comorbidities that can affect either, you know, a urologic approach or a medical oncology intervention. And so being able to have those conversations real time, you know, with your physician collaborator who you're going to be putting together, you know, some type of a plan together with, that's been incredible. Because while we all have to, you know, sometimes communicate, you know, text, cell phone kind of with our collaborators if they're in another location or on a different day of clinic, it's invaluable to have somebody right there, because we can be, you know, honest about our thoughts about what is best, but also honest about what we're concerned about. You know, what are the risks? What are the things that we want to spare the patient from? So I think it's been incredible.
Fair enough. What are some of the new, and Max, please pipe in about your bridge trial and the use of gemdosi as say an alternative or another option with BCG. Many patients, of course, come to you and have had either had BCG or are familiar with it. And again, there are still grave shortages. But you, Max, have been among the pioneers in gemdosi as a alternative or as maybe a better option. So two questions. Tell us about the bridge trial. Do your patients who come to you in this particular stage of disease qualify for it? I don't know the answer to that. And what are some of the new treatments that you are able to provide or offer to patients in this disease space that weren't even there maybe a year ago, or definitely not 5 years ago?
Yeah, I mean, it's a great question. So first, you know, thinking about the BCG shortage, which is, you know, our most recent one is since 2019. We're currently at Hopkins in a severe shortage. So
Oh, wow.
right now, yeah. So actually right now, and I'm looking at some of the patients and some of the patient advocates that are signed into this, and some of them are actually experiencing this right as we speak. We really only have enough BCG for induction courses right now. So most patients getting maintenance are sort of on a waiting game until we get more vials.
What, Max, I'm going to
Yeah,
interrupt you. What, I mean, it's been bad, but now it's really
yeah.
bad. is
Well,
it
these
just
shortages are cyclical. They're cyclical and they're geographic. So, you know, and they're bizarre. And as we'll talk about the bridge trial in a second, but you know, as I probably get somewhere between around 10 emails a day regarding the trial. I'd say sometimes half of them are regarding BCG supply. And you know, and it's bizarre, you know, a place in Philadelphia will not have BCG, and then you know, a place in right next door will. I mean, and you see that over and over again. And then, you know, certain regions won't have some, and then others will be like, we're fine. So I don't quite understand it. You know, but it's ongoing. There's clearly not enough until until Merck builds their new factory, which was supposed to come online in 2025. Now we're hearing maybe a little later, so we'll see when it actually starts producing more BCG. A trial which David was a part of, the BCG Prime trial, is trying to get Tokyo strain BCG, a different strain that we all think is basically the same, to come online. So we'll await the results of that trial. But if that trial shows that a different strain of BCG, called the Tokyo strain, is equivalent to the Merck's Tice strain, then that will help the supply. But really, for now, we have a problem. And so probably 10 years ago, over 10 years ago, a gentleman named Mike O'Donnell, a urologist at Iowa, started giving a combination of two generic chemo drugs, docetaxel and gemcitabine, in the bladder, and started publishing very good results, but it was all retrospective, which means he would treat the patients and then write up the results afterwards. And so we found it very compelling that during these shortages, this was being used. And so in 2020, we started a trial of 26 patients during the shortage. And some of those patients, who are amazing people for joining that study, are actually signed into this Zoom. So 26 patients who received gemdosi, induction and then maintenance therapy, and these were all newly diagnosed bladder cancer patients, were put on, and we followed them for now 2 years. And our results are being probably, fingers crossed, will be accepted within the next week or two. We got what's called minor revisions, which basically means that the reviewers really liked it and basically accepted it, but wanted us to make a couple changes. So that trial should be published in the Journal of Urology later this year. And we demonstrated that among those patients, the 85% of them did not have tumors come back within the first year.
Wow.
So that gave us more confidence in writing a randomized trial, going head to head against BCG, which is a trial that Noah and I worked on together as a team with a number of other you know, people who were instrumental in designing the trial. And ultimately, you know, it's open currently. We enrolled our first patient almost exactly a year ago, and a year later, we have over 330 patients enrolled out of 870 patients total, and they're being randomized to BCG versus gemdosi. And really, we're not trying to show superiority to BCG. We're really trying to demonstrate equivalency, because our goal is to provide an alternative to BCG during this, you know, given the context of these intense shortages. So that's the idea of the bridge study, and it's open in 50 centers really throughout the country, and as I said, been rolling quite well. But beside that, we have many other trials at different disease spaces. Some of them I lead, some of them Noah has both written, designed, and leads. And then we have drugs that are FDA approved, in which we are the first, one of the first 2 or 3 hospitals in the country to give. So an example of that would be Adstiladrin, which is a drug that was FDA approved 2 years ago, based on work that David did with collaborators in the lab at MD Anderson. Colin Denny, and specifically who they worked very, very closely on. This is a gene therapy that was FDA approved 2 years ago, but really because the company was like not really prepared for the FDA approval, we didn't really even have access to it until December, so 3 months ago.
Meaning
And
there was no supply, there were supply
there was
issues.
no supply. Yeah, so one of the things, when because of our size and our volume, we could be pretty aggressive, and we were very aggressive with the company and very aggressive for our patients as an advocate to be one of the first institutions to have access to that drug. And so we've treated almost a dozen patients now, just in the last 3 months, with Adstiladrin on label, which means, commercial supply, FDA approved, not a clinical trial. And so that's really exciting for us because that gives us an alternative for patients who maybe aren't eligible for a clinical trial or have kind of run through the course of many treatments, and we really don't think need to have their bladder removed quite yet. So that's very exciting. Yeah, I'll just leave it at that. I could keep talking about this
I have a question for you. Gemdosi is from my understanding, they're very old chemotherapy drugs. They've been around forever. They're just being repurposed in a new way. Can a patient, at the doctor's suggestion, receive Gemdosi without being on a trial?
Oh yeah, and that happens all the time. I mean, that's exactly what we do for patients who recur after BCG.
Trial is validating.
This trial is trying to demonstrate that it's a good idea instead of BCG.
Okay.
Now, would I recommend somebody do it instead of BCG? No, I would not. Okay, because that has not been proven. But but to your point that these are old drugs, I mean, the history of medicine is basically that of things that are old are new again. That's like half of discoveries is just repurposing things for different uses.
Well,
And then the other half, everything's like a lot of things are like that. And then the other half is like discovering new things that we didn't really know about. And oftentimes the new things that we didn't even know about are not even used in the correct context when they're initially starting to be used on patients. And it takes us a while longer to figure out the perfect kind of person and disease to actually use that in. So it's pretty interesting.
A couple of other questions. Karen asked, so for your fantastic clinic, it's a happy day on Monday. You get to see Max and Noah. Important question. Do patients get one charge or separate charges for each specialty?
So they get separate. So I mean, from a fun.
I think you just froze, Noah. Did you just freeze a little bit?
Oh, man, I was really hoping he was going to answer that because
he'll come back.
A billing expert because I don't know anything about this topic.
We'll let him
unfreeze
and come back. Sorry, Noah, you're frozen. Oh, here you are. We missed it. You were frozen for a second.
Maybe it was because I was talking. I don't know. But I was going to say they get two separate charges because you can functionally think about it as two specialty consultations. They just happen to be back to back,
right?
And we keep them in the same room. But the day of it is technically two visits.
Okay. Yeah. And Karen also asked a fantastic question. For the bridge study, Max, how long are patients who enroll, or how long are they followed on the bridge study? Is it 2 or 3 years, something like that?
No, it's actually out to 5 years.
Whoa!
Yeah.
Wow.
Yeah. So what's really going to be really cool that we sort of squeezed in is even if they recur. So say you get BCG and you recur and you switch to Gemdosi, we're actually still following those patients because there's a lot of questions that come up about, well, if I start with BCG and then I go into Gemdosi, should I have started with Gemdosi? Like we're basically assuming that, okay, say the trial shows that they're equivalent, that the real questions, the next questions patients are going to ask, we want to at least have some semblance of being able to address those questions. So we're trying to follow patients as much as we can to learn as much information as we can, because these types of trials where you have 900 or so patients, they don't come around every day. So we want to be able to glean as much information as possible, to be able to try to address as many questions that somebody might have,
Is the goal, Max, that someday soon, maybe 5 years from now, after you have your results or you're publishing soon, is that gemdosi would be a standard of care?
That's exactly right. Yeah, so if the trial is positive, which basically means that these drugs are equivalent, then gemdosi would be a standard of care, and that would be very enticing for a lot of different reasons. BCG is incredibly difficult to manufacture. We think that BCG may have more side effects than gemdosi. The toxicity with BCG is not zero, as many of my patients who are listening in right now know very well. We'll see how everything shakes out, and then there's the whole precision discussion, which is if they're equivalent, that may not mean they're equivalent for every patient. Some patients' tumor may be more susceptible to one drug versus the other. And that's where things get interesting as well, right? Can we start one patient on one drug versus the other? So that's pretty exciting as well.
Okay. Now I have one more pick on Mac's question. Max, you're a surgeon, and I find it, I mean, personally, I find it so commendable that you spend really a lot of your time trying not to do surgery on your patients. And we love you for that. Organs, bladder sparing is a big thing for patients. And this clinic that you're running with Max and your life work and the bridge study and all that, is that your goal? Is like you'd like to do the least amount of invasive surgery as you can on your patients and keep them on, again, that chasm of high risk, non-muscle invasive. You want to keep it non-muscle invasive. Is that kind of the goal here, and not to do surgery?
I think that the overarching goal that both Noah and I have is to maximize our patients' life while also maximizing their quality of life. And so what does that actually mean is pretty interesting. I mean, I'm happiest in my life. There's no place I'm happier than the operating room. I mean, close
Really?
my eyes, take me to my happy place. Absolutely. There's
We're learning
no
things
place.
about Max.
There is no place I would rather be. I
Kidding.
mean,
Wow.
in my core. Yeah. It is kind of interesting that a lot of what we're doing is trying to avoid
You out of happy.
take me out of my happy place. But I actually think it's in this conversation that may be true. We're trying to find alternatives that preserve bladders longer and better. But the flip side is that some of these systemic therapies that we're giving for more advanced disease are allowing patients to live and live meaningful, much longer lives with advanced bladder cancer. And much of the time, bladder removal is starting to play a part in that disease space. So what I always tell urologists is we are going to stop taking out bladders that don't need to be taken out, sort of maybe the straightforward surgeries, and increasingly we're going to be asked to remove bladders for patients that have more advanced cancers that are responding well to therapy, but sort of have persistent tumors in their bladder, or various reasons why you would want to remove the bladder. Maybe it's toxicity, and those are much more complex surgeries. So what's going to be asked of us is going to be more in the long term. But it's changing. The role of the surgeon in this disease space is and should be changing.
Right. Wow, that's fantastic. I have a question for both of you. Well, first of all, John Hare, thank you for asking a question. Where can we find a listing of bladder cancer clinical related, clinical trials related to bladder cancer trials? So I guess the question is, where can he find a listing of the bladder cancer trials? I think the place to start might be to email us, John, at bladdercancer@jhmi.edu. That's where we start, and field questions, and then we can put you in the right, give you the right answer if I read your question properly. Bladdercancer@jhmi.edu. That sounds for Johns Hopkins Medical Institutions.edu. And if you email us, we do respond. It is monitored, and we'll find that answer for you. Also on the website, we do have a website. There is a click for bladder cancer clinical trials. And then if you Google clinicaltrials.gov, this is Noah's terrain. There are also many, many listings of trials, but they're somewhat hard to read if you're a layperson. They're Noah, answer that question for us.
I mean, I would agree if you want a comprehensive list of clinical trials that are available both at Johns Hopkins, GBCI, but also across the country, they all are required to be registered at clinicaltrials.gov. But it can be a little bit overwhelming, even sometimes, as a physician trying to keep track of, what's there, because you may get a list of, 200 trials and trying to sift through the filters to find out which ones are non-muscle invasive and then which ones qualify. But I think, as Stephanie mentioned, we are always receptive to questions and willing to answer them at any time. Because also, I think contacting us is also a good resource, because the clinical trials menu, or the portfolio of what is active and open today, it is a moving target. We try to always have at least one, if not more, clinical trials available for every stage of bladder cancer. But we are constantly opening a new one as, another one finishes. So sometimes what you see on some of the national websites like clinicaltrials.gov, they may only be within 3 months up to date. So any questions, we're always receptive to fielding them.
Yeah. And then Karen, thank you, Karen, also reminds us that on the Beacon website, Bladder Cancer Advocacy Network, they have a clinical trials tab, and it's very user-friendly. So thank you for that. Carrie asks, for patients that you have seen in the multi-D clinic model, is their treatment, but their treatment may be being managed by another physician, how often do you recommend a patient check back in with you?
I mean, I can answer this. So this happens all the time. And I think it speaks to, I mean, we're in Baltimore. So Baltimore, I'm a Texas boy. Like, I'm from South Texas. So in Texas, there's not a whole lot. I'm from San Antonio. You do a 4-mile radius of San Antonio, you barely get to Houston or Dallas. There's not a lot. Okay. So when you do a 4-hour radius of Baltimore, I mean, it is like, I don't know how many millions of people. It's a lot of people. So frequently patients will come for second opinions, and then we'll work with their physicians in their own community. And basically, the way it usually works is we'll design a treatment plan. We'll decide if they're going to get their treatments at home, if they're going to get their cystoscopies at home, or both. And basically, if that's the way it works, I say, contact me if things aren't working. Basically, if you have a recurrence or you have some toxicities. Otherwise, you could just contact me whenever you want, or contact our team. So that's a typical way. Sometimes patients have treatments at home and come in for their cystoscopies. And that, and that's fine too. But we really want to be a resource for community urologists and oncologists. We don't view ourselves as the place where all patients are coming. That is not a sustainable growth strategy. A much more sustainable growth strategy is having in our mission statement education. And that's not just education to patients, but it's education to other urologists. So I would say a couple times a week, I'll speak to other urologists about how to manage a toxicity, or what they would do in a certain situation. And sometimes those patients don't send their patients to Hopkins. Sometimes they do, and I send them back. So all these things, there's not an easy answer to that, but it's a dynamic answer that's built around the educational mission.
Right. No, I have a question for you. There are many, many new therapeutics and immunotherapy drugs, enfortumab vedotin, and all these, kind of very exciting new remedies, I call them. Are they being used in this non-muscle invasive space yet?
Yes, they are starting to within clinical trials.
So within a trial, but not
Yeah, they have not
a trial. Okay.
specifically. Let me break it into kind of three main categories. So the immune checkpoint inhibitors, these are agents that for what we're talking about target PD-1 or PD-L1. And some of the medicines in the metastatic space that people have heard of are like pembrolizumab or Keytruda, nivolumab. Pembrolizumab is currently FDA approved today as standard of care for BCG unresponsive carcinoma in situ. So that drug is actually available and is considered a standard of care that is an option for those patients. A different class of medicines that are now making a big difference in metastatic patients are what are called antibody drug conjugates. They do have some immune properties, but in simple terms, we sometimes think about this when we're talking with patients as targeted chemotherapy. They allow us to give much higher doses of concentration into the cancer cell than we could otherwise. Those are not approved by the FDA for non-muscle invasive bladder cancer, but they are being studied in the context of clinical trials, which Max is leading at Hopkins for drugs like N4-2mab. And there are others on the runway. And then lastly, drugs that are now approved in metastatic patients that target specific genetic changes in the cancer, most notably the FGFR gene. There is a drug called erdafitinib that is approved for metastatic patients whose tumors have an altered FGFR gene. That drug has been studied in clinical trials in non-muscle invasive bladder cancer. We are studying a similar but different drug called pemigatinib. And there are some very interesting trials being done that are looking at very innovative and very slick delivery devices to actually instill FGFR targeting medications within the bladder, all of which are going on in clinical trials right now. So we're hopeful, that some of those will result, in new drugs available as standard of care. But I think we're a couple years away. I think the trials have to finish.
Right. That's really exciting. I have a question for you both. The ADAPT bladder trial, which is Noah's brainchild, has a component, as I understand it, that has radiation. Do you ever suggest radiation therapy for your patients?
I'm waiting for you to bite on that one, Max.
For
NMIBC.
For NMIBC, I mean, I would say, I think that it needs to be studied more for me to make that recommendation. The patients that, and some of them once again are on this Zoom right now, the patients that had radiation on the ADAPT bladder trial, that was part of a trial. We were learning about it. I think I would need to see more data around it. I'm really excited by the idea of what I would call focal therapy for bladder cancer. That's sort of a term that's used more for other cancers than for bladder cancer. But I sort of think about it as radiation being one potential form of that. But
I'm sorry, Max.
Focal therapy, yeah. So it's this idea that you're not gonna try to remove the whole organ, but you're gonna try to treat just one area of an organ. And this was blasphemy for bladder cancer for many years, because we were always taught in medical school and then in residency as a urologist that bladder cancer is a field defect, meaning that if one part of the bladder is diseased, by definition, the whole bladder is diseased.
Huh.
And what we're learning is that that may be true in some patients, but it's certainly not true in all patients. And so this idea that we can treat just one area of the bladder is something we're looking into. So we have a clinical trial right now that we're going to be launching in the near future in which we are actually injecting basically a locating agent underneath the tumor and then lasering the bladder, and the laser is honed to what we've injected. So it's only hitting that area of the bladder and really only hitting that tumor bed. And so like that's an example of like focal therapy for bladder cancer. So yes, I view radiation as being promising, but I really view it in the context of this idea of focal treatment for bladder cancer.
Wow, Star
Yeah,
Wars.
I would kind of follow with that too, that within the context of the ADAPT bladder trial, the radiation arm that we studied, we were using radiation a little differently than we normally use it. We were only giving 3 radiation doses in 1 week, and we were trying to stimulate an immune response to synergize with the immune checkpoint inhibitor that was also being given. I think radiation has potential, and I do think that there are some ongoing studies that are being led by the NRG and within the cooperative groups and other areas. A lot of those are targeting papillary non-muscle invasive bladder cancer because you have something that's a little measurable, and can study the effect. It gets a little trickier, I think, with carcinoma in situ. Even as simple as with the radiation from the radiation oncologist, how do you set up your field? Do you radiate the whole bladder? Or as Max says, if there's a focal lesion, can you target radiation? So I think it presents an interesting option. We certainly use it. It's effective for muscle invasive bladder cancer. I think we're going to need to learn a little bit better within clinical trials, if and where, to place that for radiation.
So I have 2 questions. The first one's an easy one for Max, and the other one's a big one for both of you. Okay, so Max, this actually harks back to another conversation with David. One of our devoted followers here asked about blue light and it being discontinued and for carcinoma in situ. Can you give us and I emailed you and you were kind to answer, what's going on with blue light? Is it being discontinued, and what does that mean?
Wait, so sorry, can you repeat?
In a former webinar, a patient was concerned because she had heard that for carcinoma in situ, where blue light cystoscopy had been available, apparently it may be being phased out.
Right.
The technology.
Yeah.
I wrote to you because I always ask you the hard
Yes,
question.
that's right. So
can you just sort of extrapolate what's going on?
that? Yeah. So blue light cystoscopy is not being phased out for rigid cystoscopy. So when we bring a patient to the operating room and put them to sleep with anesthesia, we still are able to use blue light cystoscopy using rigid scopes. It is phased out. It's not being phased out. It is phased out for flexible cystoscopy, where for patients where we're doing awake cystoscopies for surveillance, we're not able to use blue light. The reason for that is largely financial, because basically the actual dye in the setting of a hospital, it could be billed to insurance, but in the setting of like a surgical center or places where cystoscopies are done for not under anesthesia, it could not easily be billed directly to insurance, and so there was really no model to fund it. And to be honest, at Hopkins, we did not we never used that technology. We did use it as part of the trial, but we still routinely use it for rigid cystoscopy and TURBTs. And I find it very useful for CIS. To be quite honest, the more experience you have doing these cases, the more you're able to identify CIS sort of on white light with experience. But particularly, for cases where there's a urine cytology that's positive and you can't figure out why or where it's from. In other situations, blue light is very useful. So it's a complicated answer, but yes, it's not available for some and it is available for others.
Right. So here's my big, deep existential question for you both. So you seem very passionate about your patients and we applaud you. And I know it's genuine. You follow them because of the nature of bladder cancer. You tend to follow them for a very, very long time. You see them often. It's more of a frequency and hopefully a wonderful partnership. Tell me what you learn from your patients as they go through this journey. And there was a beautiful question, which I can't read anymore, from one of your patients who's been with you, I think, Max, for a very long time. And you've been through a lot together. What is the most valuable lesson you learned from your patients that makes you a better doctor?
Well, I think honest conversations with them about, what their goals are of their care and what the real impacts of some of the testing that we do and some of the interventions that we're attempting to do, how does it really impact their life? And I think honest, direct feedback on a real-time basis, sometimes, is it worth it? I think sometimes in academics, we have the luxury of being able to be creative, trying to think about how do we push the bar? How would it be possible, for the patient to do better, with some of the therapies that we have? But we always have to keep that in mind in the perspective of, these are real human beings that are volunteering, to be part of this process. And in my mind, it's not good enough to just have an idea. You have to see the other side of it. And is that idea good enough that you think that there is real potential for benefit, that it is worth sort of taking an uncharted course? We get that every day from our patients, and I love it. I mean, I think it keeps us grounded, and I think it keeps us on the right track.
Mm-hmm. How about you, Max?
Yeah, I mean, I think that what Noah said is beautiful. I mean, I became a doctor because I woke up, on weekends I would do rounds with my mother. My mother was one of the first geriatricians in the United States, and was sort of grandfathered into the field when it came into existence in the early 80s. And we would go to nursing homes and we would go to the hospital together. And I so remember her asking her patients, what is important to you? Back to Noah's point, what is important to you? What do you want? A lot of these patients would be on 10 different medications, and they'd say, I don't want to be on 10 medications. I want to be on like 2 or 3. And she'd say, okay, well, then let's figure out what's a cut. And so I learned so much from her. And then that's been reinforced learning from my patients about just understanding what their needs are and understanding what their goals are. And then honestly, building out the risk benefit profile for them to accomplish their goals. Like everything is possible. It's just about risks and benefits, right? And instead of me making that decision for a person, like it makes sense to counsel them to be able to make that decision themselves. And that's not always easy, but that's kind of the goal. So that's how I would approach it.
Mm-hmm. Great. Well, we have 2 minutes to go. Wait, we have a question that popped up. That was a beautiful, there's a big difference when you evidently care so deeply and you listen, and listening to patients is, I'm sure they're the best teachers you could ever have. David, this one's for you. Yay. I've co-opted this entire conversation. Sorry, if you put me in front here, I'm going to talk. We have a multi-D clinic for women at Sibley.
Kind
Yes?
of. Yes.
Please?
Yes,
Thank
we
you,
do.
Karen, for asking.
Right. So that's led by Armin Smith.
And it's for men and women, by the way. It's not.
Jeannie Hoffman census. And I would say at this point, a lot of the emphasis is on optimization of surgical approaches. a lot of research being done on that. I think both of the leaders at this clinic would say that at this point, they are really optimizing treatment for both men and women. So we don't want to give anybody the impression that Sibley is just for women,
No, it's not.
right? But yeah, as we go forward, we want to implement some of these research practices as they show that they're successful, essentially. So
Great. Well, thank you all for a wonderful, wonderful conversation. If anyone is interested in more information on the MDC, let's see, it's on our website now, or it will be. We just published a newsletter. It's coming out in the next few days. So we send to all those who are on our email list. And you can just simply, I mean it, and we do answer. We make a point of that. bladdercancer@jhmi.edu. If you have any questions about anything we talked about, or just any questions about how to access the MDC or how to get hold of Max and Noah for this very unique and special, I think it's one of the first and only in the country. Is that right? That you're doing. So these are the pioneers for standards of care. We want this everywhere. We want every academic medical center, every urology clinic, no matter where it is. This is pushing the boundaries of care. And believe it or not, collaboration is new here. So this is what this is all about. And to get there, I have to say, for Max and Noah, it's Herculean to make this happen, to be in the same room at the same time. You have no idea what goes on behind the scenes. It's huge. And so we thank you both for being, the extraordinary humans you are, and incredible physicians. And David, thank you for leading such a great
oh, proud to work with these guys. They're fantastic.
Yeah. Okay. Send us your questions. Thank you, everybody. And we'll see you at the next one.
Take care, everyone.
All righty.